بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. كل سنة وانتم طيبين بمناسبة قدوم شهر رمضان الكريم. ربنا يتقبل مننا جميعا صالح الأعمال. هنراجع النهاردة الموديول بتاع ال GIT، وهو بنفس الطريقة اللي عملنا بيها الموديول بتاع الشيست. هيكون في الطريقة بتاعة الجي اي. هنبتدي بالحالة الأولانية، and this is a male patient 76 years old, presented by diarrhea, B and C viruses, negative serology, and abnormal liver function. This is the CT scan before CT guided needle biopsy, and this is the scan after CT guided needle biopsy. Yes, and this is the hepatocellular carcinoma, of course, a huge solid mass in the liver which is cirrhotic, and post-biopsy hemorrhage in the peritoneal cavity. And this is one of the complications of biopsies from the liver. If the coagulation profile is not good, and there is a chance of the patient to bleed, and this bleeding is difficult to stop. And I know some of the patients died from biopsy from the liver because of the uncontrollable intraperitoneal bleeding. Then the second case is a perimeal follow-through examination of the small bowel, of course. Yes, this is Crohn's disease, and you got multiple segmental narrowing of the small bowel, and another segment here and another segment here. These lesions are known as the skip lesions, which are, as you know, very characteristic for the Crohn's disease. And whenever we diagnose Crohn's disease, we look for the complications like the fistula tract to the peritoneal cavity or to the adjacent bowel loop. Next case is a plain film of the chest. This was a chest x-ray actually, but because of these three shadows, they did a CT scan of the abdomen, and they revealed these calcified lesions, which are diagnostic of hydatid cysts. And hydatid cysts, whenever the cyst is died, then you got calcium even throughout the whole cystic lesion. Next case is a child or newborn 1 day old presented by abdominal distension. And this is the plain film, and this is the CT scan of the abdomen. Yes, this is a system. You have to provide diagnostic differential diagnosis. The cystic lesion in the peritoneum, there are three possibilities. Either it is a mesenteric cyst or a hydatid cyst or a duplication cyst. According to the literature, duplication cyst is considered the most common of these. Mesenteric cyst is rare, and hydatid cyst needs some of the criteria of hydatid cyst, like calcium in the wall, floating shadows inside the cyst, or multiple daughter cysts along the wall of the hydatid cyst. Then if you see a simple cyst within the peritoneal cavity, the diagnosis of duplication cyst is most likely, as the mesenteric cyst is considered somewhat rare compared to the duplication cyst. Next case is a male 33 years old, 34 years old, with hypoglycemic symptoms. Yes, the answer is right. This is an insulinoma in the pancreatic head, and this is the only indication for triphasic scans of the pancreas whenever you are suspecting an insulinoma, because the tumor is usually very small and it is not seen unless you have the arterial phase. But most of the other pancreatic lesions are seen usually without the need for the triphasic study. Next case is a female 46 years old, and this is the CT scan of the abdomen. Okay, and cyst in the region of the pancreas. Number one is to consider the possibility of pseudopancreatic cyst. But you should know that pseudopancreatic cyst does not contain calcium. And if you look carefully, you may see some of the internal septations within the cyst. And this is a cystic tumor of the pancreas, which is a mucinous cystadenoma, of course. Yes, this is a mucinous cystadenoma of the pancreatic tail. A series of MRI of the liver. This is arterial phase, portal phase, delayed phase. Yes, and this is actually HCC, and there is a very important finding you have to spot here. Yes, and this is right. Invasion of the IVC. You see in the arterial phase, and the tumor is going inside the inferior vena cava, and here also you can see the tumor thrombus inside the inferior vena cava. And whenever you are reporting a case of HCC, you should emphasize the possibility of portal vein invasion and the possibility of inferior vena cava invasion, because these vascular invasions will affect the prognosis and the way of treatment of such a lesion. This is a female patient, 79 years old, presented by fever and leukocytosis after embolization of HCC. Yes, and this is actually whenever you embolize the hepatocellular carcinoma, you got necrosis and the liquefaction of the tumor cells, and this may be secondary infected, resulting in an abscess, which is a known complication of chemoembolization. Next case is a female patient who is presented by abdominal pain. Pancreatitis, and you got bulky masses here in the peritoneum around the vessels, and this is not pancreatitis, and is not an adenocarcinoma, but lymphoma. Yes, this is lymphoma. And you got enlargement of the mesenteric lymph nodes. and you got what is known as the sandwich sign, with the affection of the retroperitoneal nodes as well. The pancreas is diffusely swollen. It may be also affected by lymphoma, and this is abdominal lymphoma. 78 years old female patient presented to the ER with a small bowel obstruction. Yes, and this is good. This is mesenteric volvulus. If you look carefully at the root of the mesentery, and you got the characteristic whorly appearance of the mesenteric vessels, then consequently you got some sort of intestinal obstruction with multiple air fluid levels in the small bowel. Next case is a female patient, 62 years old, presented by this pancreatic pathology. Serous cyst adenoma, pancreatic carcinoma, IBMN. Yes, this is right, IBMN. Yes, this is an intraductal pancreatic mucinous neoplasm. It's very important if you see that the main pancreatic duct is dilated. And if you look carefully to the pancreatic head, you do not see a mass that can explain this obstruction. And instead, you see that the duct is continuous in the pancreatic head. Then this is one of the supportive criteria to diagnose this intraductal pancreatic mucinous neoplasm, which I mean is somewhat seen in the clinical practice. Next case is a CT scan of the abdomen, axial and coronal. Superior pseudocyst wandering spleen. Where is the spleen which is wandering? Okay, here you see that the duodenal loop is markedly dilated, and this dilatation ends by an obstruction. This obstruction is caused by significant mural thickening of the duodenal loop, resulting in luminal compromise. And of course, this is malignant lesion. In the proximal part of the small bowel, you favor the diagnosis of adenocarcinoma. In the distal part of the small bowel, the ileum and so, you favor the diagnosis of lymphoma. And this was a duodenal adenocarcinoma. Next case. Yes, and you have to specify that this lymphoma has totally infiltrated the spleen and diffusely, almost diffusely affecting the liver. Solid mass in the spleen, first possibility is lymphoma. Other masses in the liver, in the kidney, in the pancreas should be considered as lymphoma as well. Next case. Yes, actually, all the answers are good, but here you see an abscess in the region of the appendix, and you do not see the appendicolith around the abscess or inside the abscess. Then all what you can say that you are dealing with an appendicular abscess, since it is present in the anatomic location of the appendix, and it shows the criteria of an abscess. Next case, axial and coronal images of the abdomen. Okay, sorry for this, and you answered good. This is mesenteric paniculitis, and you see almost the ground glass appearance or the misty appearance of the mesentery with the characteristic fat halo sign around the vessels, which are diagnostic of mesenteric paniculitis. Next case is a female 60 years old with past history of lung cancer and liver metastasis, presented with history of abdominal distension. Yes, and the answer is right. This is incarcerated hernia. There is one of the small bowel loops that has been incarcerated in a narrow neck hernial sac, and consequently the small bowel is obstructed and you got multiple air fluid levels. Then this is hernia with intestinal obstruction. Every time you are assessing hernia in the abdomen or in the inguinal region, look for the possibility of incarceration and the associated intestinal obstruction. Next case is plain film of the abdomen and the CT scan as well. Yes, and you should say, of course, right, this is sigmoid volvulus, the coffee bean sign, and this is the appearance of the volvulus in the CT scan. Sometimes, as you know that the sigmoid volvulus is easily diagnosed from the plain film, but it's difficult to be diagnosed from the CT scan. And some of the examiners may start by this film, or sometimes you are confronted by a CT scan of the abdomen performed on emergency basis and look for this slit narrowing in the region of the sigmoid colon, then you go to the diagnosis of sigmoid volvulus. Female patient, 54 years old, with left-sided abdominal pain few hours ago. Yes, and this is colonic diverticulitis. You got a segment of the colon, the descending colon, with multiple patent diverticuli and mural edematous changes and marked stranding of the pericholic fat, diagnostic of colonic diverticulitis. Next case. No, yes, this is obstruction, but not volvulus. This is intestinal obstruction, and you got air fluid levels, and you got what is known as the Burle sign or the multiple air loculi underneath the valvulae conniventes, then you should say this is intestinal obstruction and start to look for the cause of obstruction. This may be due to gallstone ileus, for example, maybe due to mesenteric volvulus, maybe due to mesenteric ischemia, and sometimes you cannot see the cause. Then the cause is usually due to surgical adhesions, and or let us say due to adhesions. If there is a history of prior surgery, then this is surgical adhesions. But if there is no history of prior surgery, adhesions can occur if there is an inflammatory process in the peritoneum. Next case, and this is hernia, and you have seen it before, with intestinal obstructive changes. In the literature, there are three types of small bowel obstruction: low grade, high grade, and complete. Then, in order to differentiate between the three, just look to the colon. Just look to the ascending colon. In the ascending colon, if you got fluid, stools, and gas, this is low grade. If minimal gas or minimal stools, and this is high grade. If the colon is collapsed with no gas or fluid, then this is complete small bowel obstruction. The thickness of the wall of the obstructed bowel is usually the bowel wall thickness, the cutoff value is 3 millimeter, and above this is considered edematous. Then the bowel diameter cutoff is 3 centimeter, and above this it's considered dilated. And you try to identify the transition point between the obstructed and the non-obstructed bowel. And this is one of the signs which is known as a small bowel feces sign. You know that the small bowel contains fluid, digested food, and there is no feces or gases inside the small bowel. But in the small bowel obstruction, you got some stagnation of the food, and the absorption of water and the development of infection or something like this. Then you got a loop which looks like the colon, and this is known as a small bowel feces sign, which is one of the signs of intestinal obstruction. Next case is a patient with metastatic cancer colon presented by severe abdominal pain, nausea, and vomiting. Okay, and obstruction due myths, you do not see very good. This is closed loop obstruction. Yes, this is what we call closed loop obstruction, meaning that a certain lobe of the small bowel has trapped either by adhesions or by herniation into a narrow opening. Then you got the affected lobe is closed, and it looks like the C curve, and the points of entry and exit are very close to each other. The small bowel distal and the proximal to the lesion are collapsed. Then whenever you see this appearance, and you diagnose this as closed loop small bowel obstruction. This is what I mean. There is a loop that looks like the C curve, then the proximal and distal bowel are not affected, and the end points of the loop are very close to each side, to each other, and sometimes you got the twisted mesentery forming a Worley sign in this anatomic location. Next case. Okay, and then one of the answers is bowel ischemia, and this is a good answer. This is not the colon, this is a small bowel. And if you look carefully here, and you see that there is a filling defect in the portal vein as well as in the superior mesenteric vein. And this thrombus is the cause of bowel ischemia, and you got less enhancement of the bowel wall and very dirty mesenteric fat, and this is diagnostic of small bowel ischemia due to venous thrombosis. Then you may have a small bowel ischemia due to venous occlusion or due to arterial occlusion. Whenever the ischemia is due to venous occlusion, then you got decreased bowel wall enhancement. You may get a edematous wall because the vein is obstructed and the artery is patent. You got pneumatosis intestinalis, air in the wall of the intestine. You got portal venous gas, which is a very bad sign. Then you may got perforation and pneumoperitoneum. But if the small bowel ischemia is due to arterial occlusion, as you can see here, this is the superior mesenteric artery, and you got a thrombus inside the artery. Then you got ischemic dilated small bowel loops with multiple air fluid levels. In arterial ischemia, the wall is very thin because the wall is ischemic. But in venous ischemia, the wall is edematous and is swollen compared to the arterial ischemia. Then CT scan of the pelvis showing this lesion. Um, dermoid cyst. No other possibilities. Teratoma. Cavernoma, sigmoid cancer, rectal cancer, pelvic hemangioma. Okay, this is not the rectum, this is a small bowel loop. And this small bowel loop is markedly thickened with trapped air and the fluid inside, which is very characteristic, of course, of a small bowel lymphoma. Then this is lymphoma, yes, this is lymphoma. Okay, next case. Yes, and this is peritonitis and multiple intraperitoneal abscesses. You got multilocular abscesses with enhancing wall and some air loculi inside with dirty appearance of the fat planes. Next case. Is lymphangioma, not lymphangiectasia, lymphangioma. The only lesion which is cystic in the peritoneal cavity and creeps everywhere in the cavity around the vessels, around the organs, this is peritoneal lymphangioma. And this is not pseudomyxoma peritonei, because if you want to diagnose pseudomyxoma peritonei, you should look to the surface of the liver and the surface of the spleen. If they are scalloped, then you know you are dealing with pseudomyxoma, but this is peritoneal lymphangioma. Next case. Okay, I'm sorry for the sound, because there are since this morning some problems with the internet, and they said that they are going to fix it, but you know what happens in this country. I will just immediately after finishing this, I will send it to you through your site. Then you can hear it clearly, inshallah. And this is I don't know what was your answer. Okay, colitis, Crohn's, ulcerative. Then, okay, and then this is inflammation, because the wall is thickened with the stranding of the fat. Then all the inflammatory colitis, like Crohn's and ulcerative colitis, give the same picture. But you know that Crohn's in the colon has some sites to be affected. If you see that the lesion is starting in the rectum, then this is ulcerative colitis. But if it is in the transverse colon, for example, or the ascending colon, you may think of Crohn's disease. Both will produce this appearance of mucosal edema and a stranding of the pericolic fat. Next case. 48 years old with upper quadrant pain, fever, and leukocytosis. Hepatic abscess, yes, and this is hepatic abscess because of the history and because of the appearance of the lesion. You got multilocular abscess with thick enhancing wall, and if you look carefully, you can see edematous changes around the abscess itself. But don't consider the abscess to be exactly rounded and surrounded by a very well halo of edema. No, the abscess can have a lot of configurations. There may be a big abscess and some daughter abscesses nearby. Next case is a male, 73 years old, with left upper quadrant pain, fever, and leukocytosis. Yes, but where is this is an abscess actually, but where? And this abscess is present, spleen, yes. And this is a splenic abscess. This is the spleen, which is somewhat enlarged and is totally replaced by this fluid with internal airloculi, diagnostic of an abscess. And you know, most of the splenic cysts can be secondary infected to result in an abscess. Also, splenic infarctions may be secondary infected, resulting in splenic abscess. Next case, axial and sagittal. Yes, very good. This is appendicitis, classic appearance. You got the appendicolith at the neck of the appendix. You got obstructed appendix distended by fluid and enhancement of the wall with inflammatory changes in the surrounding fat. And this is acute appendicitis. Next case. This patient presented by abdominal pain. This is the initial scan, and this is the follow-up scan 2 weeks later. And necrotizing pancreatitis, very good. Yes, this appearance is that of pancreatitis because of the swollen pancreas and the surrounding fluid. But after 2 weeks, you got, because of pancreatitis, can occlude the vessels, either the vein or the artery to supplying the pancreas. And this will result in pancreatic necrosis. And at that time, the enhancing pancreatic tissue will be replaced by necrotic granulation tissue, except for this part. Then you have to diagnose this as acute necrotizing pancreatitis. Next case is a female patient, 42 years old, with acute blood loss. Yes, very good. This is hypoperfusion syndrome. Very good. And this hypoperfusion syndrome has many criteria. Number one is decrease in the caliber of the aorta and the IVC, diffuse thickening and enhancement of the intestinal wall, diminished splenic enhancement compared to that of the liver, increase in the renal and adrenal gland enhancement, and the swelling of the pancreas and adrenal glands as well. This is the pancreas. Next case is a patient with ulcerative colitis following rectal sparing colectomy. The patient did the total colectomy, sparing only the rectum. Okay. Then, if you look carefully here and you see a mass inside the rectum, this is the rectum anastomosis to the small bowel. And at that time, you will diagnose this as a malignant, because you know that one of the complications of ulcerative colitis is to develop malignancy on top. But this lesion, when biopsied, it appeared to be a pseudopolyp. You know, in cases of Crohn's disease and ulcerative colitis, the multiple polyps can develop from the healthy, unaffected mucosa, and these are known as pseudopolyps. But if I am in your situation, I will diagnose this as cancer colon. But I put this case just to remind you that sometimes you got a lesion like this, which is known as a pseudopolyp. 65 years old male with epigastric pain. Yes, this is the classic appearance of pancreatic abscess. You got a cystic lesion in the pancreatic head containing air loculi. And I said that whenever you have a cystic lesion in a patient with acute pancreatitis, you should diagnose this as a pseudopancreatic cyst. But if you can identify air inside the lesion, and this is pancreatic abscess. Um, this is an old technique, but you may see it in the exam. Sometimes some of the examiners have these films which are known as T-tube cholangiography. They fix the T-tube inside the common bile duct after cholecystectomy before they close the surgical wound to maintain or to guard against the possibility of any stones or complications at the distal part of the common bile duct. Yes, and this is distal common bile duct stone is a smooth filling defect near the ampulla of water, which is representing a common bile duct stone. Next case is a male patient, 67 years old, with progressive worsening fatigue, anorexia, dull generalized abdominal pain, frequent bloating and constipation, and unintentional 55 pounds weight loss over 2 months. Gallbladder mass, gallbladder cancer, yes. If you see a mass in the gallbladder fossa, you should consider this as a gallbladder carcinoma until proved otherwise. Gallbladder carcinoma can invade the adjacent liver parenchyma, but I think it's very rare to see a hepatocellular carcinoma invading the gallbladder fossa. I didn't see in my practice, and also on the literature. But if you see a mass that is centered to the gallbladder, this is gallbladder carcinoma. The differential diagnosis of carcinoma is lymphoma and metastasis, as I usually say that. Then don't consider this as hepatocellular carcinoma invading the gallbladder fossa, because this, in my opinion, is rare, or I didn't see actually. Then this is the cancer gallbladder invading the liver. You see, this patient who presented after ultrasound reporting a focal hepatic lesion in the left lobe, and they want to verify by CT. Then, yes, the answer is right. This is focal fatty infiltration, not focal fatty sparing. Focal fatty infiltration, the rest of the liver parenchyma is good. And you know that this is focal fatty infiltration by the detection of the vessels going through the lesion undisturbed. There is also some pleural effusion, which is, of course, unrelated. Next case is a male, 42 years old, admitted with history of intermittent fever, right upper quadrant abdominal pain. Yes, the answer is right. This is Caroli disease, and you got cystic dilatation of the intrahepatic biliary radicals with a central dot sign, which represents the portal venous radical inside the cyst itself, and this is diagnostic of Caroli disease. Next case is a female, 45 years old, and she has a problem in the gallbladder. Yes, this last answer is good. Xanthogranulomatous, yes, Xanthogranulomatous cholecystitis. Xanthogranulomatous cholecystitis is identified by two important criteria. Number one, diffuse thickening of the gallbladder wall and enhancement. Sometimes you got cystic changes within the thick wall. The second very good diagnostic criteria is inflammation of the surrounding hepatic parenchyma. in the form of edematous changes or maybe some abscesses around the affected gallbladder fossa. In the literature, they say that it is almost impossible to differentiate between xanthogranulomatous cholecystitis and carcinoma of the gallbladder, but many times we are able to discriminate between both, and both are treated by surgical resection. هذا وبال